Switching gears a little bit, we're going to talk about cardiac. And so once again, for this talk, we're going to talk image quality and then dose optimization, all in one. But I'm going to, it didn't make as much sense to do image quality then dose at the end. So I'm basically going to talk about them both simultaneously throughout. All right, so let's just talk. What is the big picture? What are we trying to do, especially in cardiac CT? Well, we got a lot of motion. We have to do something we have to make our images very quick, and we have to do it in a way to freeze that cardiac motion, eliminate the artifacts that come from that motion, and we have to do so without the loss of any data. So high spatial resolution is very important because we are looking at very small coronary arteries, and they don't all go up and down. They're all going in all different tortuous angles and whatnot. And so we need high spatial resolution in all XYZ planes. We need good contrast to noise ratio. Obviously, if you're looking at plaques, that's high contrast, so you're okay. But if you're looking at regurgitation, stenosis, if you're looking at some other things, and you need to see the tissue, you're looking for, the list is really long. You need to have a good contrast from the iodine as a function of the overall physiological effect that's happening in the image. And then you'll see, well, yeah, of course you need low contrast because you're looking at both soft tissue images plus soft tissue that has contrast in it, obviously interluminary. So this is something we talked a little bit about last week, and we actually talked about it just a minute ago, about patient setup. In fact, one of the people in the audience asked this question. When we were talking about setting up the patient, should you position the patient in the center of the gantry, or when you're doing cardiac image, should you place the heart at the center of the image? And I was of the opinion that you should put the body in the center because it makes the most sense for because the bow tie filter is shaped for the body. It's not shaped for the heart. And then one of your wonderful viewers said, tell me more about Hitachi. And so I did a lot of reading about Hitachi this week. And guess what? Hitachi actually has a very specific bow tie filter meant for cardiac imaging. And so this may have been the exact same person that asked these two questions. I'm not certain, but that's very astute. And so this is something I didn't know. So I have to admit, I learned something new this week. In this example with the Hitachi, the scanner, the Hitachi scanner, it actually has that filter. And so the whole idea is actually placing the heart at the center of the field of view. And so you can use the cardiac bow tie filter plus their ability to do lateral table shift. And that gives you the ability to, in theory, optimize the spatial resolution and the radiation dose within that field of view. So you're imaging for the heart, you're going to get the best image quality in that heart field of view. You're going to get pretty good dose reduction in what I was able to read from the Hitachi papers out in the publications, is they were quoting about maybe 25% dose reduction to the heart, in that field of view. So you have to use the right filter, the right location, get the heart actually centered using either physically manually moving the patient over or using their table shift. And then you will set your actual scan field of view to be smaller, to the same size as that cardiac bow tie filter. There is a reason in this example why you would actually center the heart in the gantry, not the body. I would argue still, and once again, this is still my opinion, that for the vast majority of CT scanners and for the vast majority of patients that you will scan, the best thing to do is place the patient centered in this gantry. The nice thing about the heart, as much as it is obviously offset a little, it's actually not that far offset. The heart is still mostly central to our body. And so at most, we're only moving a couple of centimeters over if we actually physically moved the patient over. That said, if you're using a traditional body bow tie filter, it's contouring the dose and the image quality to the shape of your body. And so by putting the body centered, it's going to get you the best image quality at the center and the best dose optimization at the center and the sides. So if you're using a smaller cardiac bow tie filter and a smaller field of view, then it's going to look really good in the center, but there is the potential to have some artifacts on the rest of the body in the image. So thank you. That was a great question. It's a great comment from the viewers. Gave me a chance to learn something this last week. And so the answer is, should you set up the patient in the center or the heart in the center? I personally believe now the right answer to that question is it depends on the scanner you have. And if the scanner is optimized for a heart centered approach, then yes, you could do that. If you do not know if your scanner can do that, obviously you can reach out and talk to the vendor of your scanner. But the safest bet is just to put the patient at the center too. Okay, so getting into really what are we going to do to image quality and dose optimize a cardiac acquisition. So a CTA as an example. We need to optimize all of these things. And that's actually quite a long list. And so when it comes to doing imaging, Tanya mentioned it's actually not that easy. In fact, probably one of the more complicated anatomical and physiological aspects of CT imaging in the body. And so we're going to go over this entire list. How do we optimize tube current, tube voltage, scan time, the rotation speed, pitch, the type of way, the way we imaged? Are we going to do prospective imaging versus retrospective? And I'm sure most of you know what that means, but we'll define what those are. The type of ways, are we going to do helical versus axial or, step and shoot sequential imaging? How are we going to, the field of view, the beam collimation, the filter size, all of these things, we're going to talk about them. Reconstruction size, types, iterative reconstruction versus deep learning now. I have some images of deep learning in the heart. And then, of course, slice thickness and all that kind of stuff. So let's just go through this step by step because there's a lot of there's a lot of ways to look at this. And actually, when we break it down, it can actually be fairly simple at each step. So what is the right MA to use? Well, that actually has a lot more to do with what are you trying to image. As we mentioned, if you're doing calcium scoring, these types of images have become the new type of routine clinical image, much like lung imaging and mammo screening. More and more centers, more and more hospitals are doing routine calcium scoring tests. Now, I'm not a radiologist, and I can look at that, and then obviously I know where to put my ROI, and I know how to do my calculations based off of that plaque that I can see here. And so you don't need a lot of photons to get that image right there. And therefore, obviously, you're not injecting iodine in the image. And so you can optimize the MA depending on the clinical task. Whereas if you're doing a nice CTA, you want it relatively noise free because you want to be able to see the finest structure, obviously not seen in this, but if you're looking at the LDA or any one of the coronary arteries, you do need to see that structure. And if it's too noisy, it's hard to see that. So we do tend to use a higher MA for these more complex CTAs. So, and we're going to talk a little bit about the tube modulation and the tube current modulation and other ways to optimize the MA when we get to another stage in the optimization process. Which KV do we use? Well, older systems, if you have an older system, you're basically limited to 120 kV. So there's not much to optimize there. But for those of those systems that have more power, and they have a larger generator, then you can typically use a lower KV. Or if your patient's smaller, so you just don't need as much energy power, you can do more of your patients at lower KV. So a couple of things. Remember, we talked about this last week. KV, the radiation dose changes by the square of KV. So therefore, going from 120 to 100 KV reduces the patient dose. But just like, quote unquote, those monoenergetic images we were looking at a minute ago, when you shift towards lower energies, the intensity of the attenuation because you're using more photoelectric effect, the intensity of the attenuation in these images is much greater. Therefore, the contrast is inherently much greater. And so you can get nice, clean images at these at the lower KVs. And so just the contrast really just steps out, just kind of pops. And here you can see this is a 70 kV image compared to an 80, 90, 100, and 120 kV image. And so tube current, when there was a publication that came out and they asked this question, so it's almost 10 years ago, they asked the question, if I use a lower KV, would the image quality and the diagnostic task be affected? So when the radiologist looked at it, they had a 0 to 5 scale, and they were able to rate the quality of all of these images, and they did it as a function of KV. And here you can see it's basically the same. In almost all cases, the radiologist said the image quality was sufficient at 100 kV, and therefore we can go from, say, 120, which is going to be a little less contrasty, to 100 kV, and there was no effect in the overall ability to do the diagnostic test. It just actually looked a little better. That said, the radiation dose was statistically significant. In other words, the radiation dose did decrease at the 100 kV than the 120. So optimizing using lower kV wherein possible gives you better inherent contrast to noise in the image and less radiation dose to the patient. Okay, so let's talk, for example, speed. This is obviously the hardest thing to do. When you are imaging a moving target, you have to move faster than that target, or it's just you will have motion blur. It's simple. So when you look at here in the US, we have the what is it called? The North American Society of Cardiovascular Imaging, or the NASCI. They basically say the target heart rate for, say, a coronary CT exam is about 60 beats per minute. If the heart rate is much higher, that's when they say it's probably okay to use beta blockers to try to chemically reduce the heart rate to get it to a manageable or reasonable rate so that we can image with a CT scanner. Physiologically speaking, normal resting heart rates are somewhere in the, if you're nice and healthy and everything's going well, you're in the 70 to 80 range. Obviously, it can get up to 100. It's just normal. There's a lot of fluctuation. Just normal physiological spread. Let's talk about what can we do for the CT scanner. Well, most scanners right now, the fastest scanners out on the market are about a full rotation time it takes about a 0.25 seconds or a quarter of a second to go all the way around. If you're imaging with a system that can go about 0.25 seconds, you are able to image a 70 beats per minute heart without motion. You can freeze the motion. That's a good thing. Now, if you want to image that same patient that comes in and their heart's racing at 100 beats per minute, well, your rotation time would actually have to be about 0.15 seconds. And there is not a CT scanner on the market that can do that. And then if you want perfect, ideal, completely motion-free, crisp, clean margins, you actually need to be imaging at roughly approximately 50 milliseconds, which is just not even possible. So it's 0.05. And that's not even close. If we can do 0.25, 0.05 is not even close. So most scanners can't do this. Some scanners can at least do 0.25. Now, that doesn't even approach the fact that we have little kids, neonates with really high heart rates. You have people that are just sick or stressed out because they're freaked out about getting a CT scan and their hearts are just racing. So let's talk about how we can approach different ways to image the heart. Obviously, we can give them beta blockers. We can chemically just lower it. So that is always the option. That is hopefully an option. If it's not an option, there are still ways that we can image the heart, a fast moving heart. So let's talk a little bit about the other aspects going on. So we know there's the cardiac cycle, And that takes somewhere around the zero point 0.6, about a half a second to a second to go all the way from systolic to diastolic in the heartbeat. Obviously, every heart rate, every human has irregularities. We're not perfect heart rate or heartbeats. There are always going to be times when we might have an arrhythmia, or there's just that where something along the diastolic to systolic spectrum, something just changes. We skip a beat, or something happens, and something's just not right. So these are the three things we need to optimize. Obviously, the amount, the rate, the beats per minute. Then we need to image within the cycle so that we know diastolic to systolic, or I should say systolic to diastolic. We need to image within that range, and then we need to be able to take into account when the heart doesn't actually do the same rate over and over and over and over again, where it skips a beat, where it has an arrhythmia or something. We need to be able to account for those three things. Okay, so in a perfect world, we'd just stop the heart and then we'd image it and then we'd turn it back on and keep going. Can't do that. We can ask our patients to hold their breath for a couple of seconds. we can't ask them to stop their heart for a couple of seconds. But we do have a heart that does naturally stop itself for just a split second. And it's in the systolic phase, of course. So we go systolic to diastolic. There's going to be that moment where it actually has low cardiac motion. And so people have gone out and they've measured this. And depending on your heart rate, how fast your heart's beating along the x-axis right here, tells you how long the heart will be in a diastolic phase. So for low normal resting heart rates, maybe the 70 and 80 range, you're spending about a half a second in diastolic phase. Unfortunately, when you get a little more, your heart starts racing, or you're just unhealthy and your heart rate's already up this high, to image in the diastolic phase where there's minimal low cardiac motion, your window, your time frame decreases substantially, going from 500 down to 200 milliseconds or even lower. So imaging a fast moving heart only gets harder because we have a much smaller target to hit if we're trying to image in the diastolic phase. Sorry, there we go. So what we're going to do is we need to be able to image that. And so then the question is, how do we image that? Because we have two options. We can do pitch or we can do axial imaging. So the vast majority of CT scanners are able to do pitch. In other words, they do helical imaging. And so we have to take into account the type of pitch, how much the table will spin, how much the CT scanner will spin as a function of how fast the table will move the patient through the scanner. So to cover the heart, we need, I don't know, say roughly 15 centimeters, 150 millimeters. That's just an average size heart. Nothing, no cardiomegaly, just a normal average, craniocaudal or, superior to inferior dimension of a heart. So if that's the case, then we need to be able to image the heart in a way that we sample the heart as it goes through all of its beats. And so if we just simply go straight down through it as fast as we can, we're not actually going to image the heart perfectly stationary. It's going to be compressing. It's going to be going from systolic to diastolic. So we actually go the opposite route. We go as slow as we can when we do helical imaging. We do very low pitch, 0.2 to 0.4. So it's sitting there spinning as the heart is beating, and it's able to then sample the heart all the way through its full cycle, systolic to diastolic, one heartbeat. It's able to cover that as it then goes over the entire heart rate, over the whole physical aspect of the heart. So it's important to know that we can obviously, the way we reconstruct that and when the x-ray tube is on as it's beating through that, we'll talk about in a second. But if you're setting the MA such that the system will change the MA, the tube current modulation, as it spins around the body, because obviously we're imaging the heart here, but that's going to be passing through a larger, wider aspect of our bodies laterally versus anterior to posterior. So if we do tube current modulation, then remember, dose and pitch are separated. You can have low pitch and high pitch, and you can have the same dose output. But if you're using a fixed tube current, which some people still do when it comes to imaging the heart, then there we go. If you go really low dose, if you go really low pitch, the dose is going to go up. Obviously, as you're sitting there spinning, if you're going to cover the same part of the body 2 or 3 times before it moves a little deeper into the body, into the scanner, obviously the dose goes up. That is only true if you're using a fixed tube current. So the ideal case here is if you're going to be able to cover the image, if you're able to image the heart with an axial single spin, if the scanner itself can do 16 centimeters, 160 millimeter coverage, that's wonderful. But for the most part, most scanners out there are limited in their overall coverage. Therefore, they're going to use they're going to use helical imaging, and therefore they need to use really short or really small pitches so that we can really sample the heart. And the way we're going to do this is we're going to try to image in that dystolic phase where there's little motion. You can kind of see in the overall heart rate, and you can see the trace of this EKG. You can see there's a lot of motion, in the systolic side, but when you get to the dystolic, it's pretty quiescent, relatively little motion. And so we want to acquire as much information, use that phase of the heart to acquire as much of the image data as we can. If you have a sufficiently fast scanner, you might be able to acquire all of your information in one spin in this phase right here. Remember, all we need is 180 degrees plus a little bit more called fan angle. The 180 degrees plus fan angle. If you have that much data, you can reconstruct the image. You don't need a true 360-degree rotation in the heart. And so one way to help speed up the image acquisition is we don't actually acquire the full rotation worth of data. Now, if you cannot spin that fast, then like I said, sometimes you have to spin over that same part of the body 2 or 3 times. But we don't want to do, what we can do is we can simply turn the scanner on and off at that exact same location, and we just do it multiple times, 2, 3, 4 times, however we need to collect enough of that data to get that 180 degrees plus fan angle. So it's not necessarily that we're just going to sit and scan and overexpose the patient. But if we use what's called prospective EKG gating, we hook up the patient, set up the EKG, so we're collecting the heart rate, the trace of the heartbeat. We can then tell the system, the computer, the CT scanner can then see that trace and know when to turn on and off and on and off the scanner to collect the information it needs, but to do it without overexposing the patient. So this is what we call prospective EKG gating, where you turn on the CT scanner only at a certain location along the heart rate, along the heartbeat. There are 2 ways to look at this. There's what's called a fixed time approach, where when it catches, so on the typical QRS spectrum, when you're looking at this heartbeat, when it goes from the peak, which is the R, once the CT scanner sees the R peak, it knows to immediately turn on the CT scanner at a fixed time after that R peak. And it will always turn it on, irrespective of what's happening right here. If for whatever reason the heart rate races and it goes a little quicker, and that the second R peak gets compressed, or if there's an arrhythmia or something, if you're using a fixed time, typically the system will always turn it on and it'll always acquire it right then. And so it can potentially maybe miss that dystolic phase. The other way to do this is what's called percent delay, where now instead of saying, okay, go a quarter of a millisecond after or a half a millisecond after, it's going to do a percentage of the time. And so in this case, what happens if we want to image when the system sees the R peak, we can tell it to go, say, 60%. So it knows the time from R to R because it's sitting there measuring it. It's measuring the heart rate throughout before the CT scanner ever turns on. So it knows what an average R to R interval time is. And so if you say, I want you to go at the 75th percent of that, or the 60th percent, or whatever it knows what it is. And so when it sees the R peak, it counts down the time and it will acquire that. Now, it should be said that in both cases, it knows what the R to R peak is basically because it's been tracking that, it's been measuring that. Every so often, the body will throw out, obviously we'll have an arrhythmia or something goes on. And the system needs to be able to recognize there's a divergence of the R to R. And so if it's going along and it knows the R to R peak is whatever that time is, but then all of a sudden it measures something that's a little different. Well, it's going to stop. It's not going to acquire any images until the R to R peak gets back to its normal average. And then it'll start acquiring data again. And that's just their way of making sure that it's more accurate at collecting the data at that specific dystolic phase that you've asked it to. And so it's a good way to keep the radiation dose to the patient low, because if you're acquiring a bunch of images and you have arrhythmias or other issues and there's a lot of motion in the heart, well, when you go to reconstruct the image, it might not look good enough. You might have to do the exam again. So usually we set it up so we're doing the percentage time, the percent of the R to R interval. Where do we typically want to image? Well, traditionally, people say 70% or 75%. So let's look at that for a second. In this example, coming out of Johns Hopkins, it's a university hospital here in the US. If you look at the systolic phase over here, the QRS and T complex, after a certain percentage of time, if you go about 70%, that is basically dystolic. If we hit it right and the heart rate is consistent and it's good, well, the motion is going to be not as blurred. And you can see here, looking at this coronary artery, it looks nice and crisp. The edges are well defined, nice and conspicuous. And so this is what you're trying to get, a nice, clean, solid image. Now, if you imaged for whatever reason over here, say 20, 30%, or for whatever reason it acquired right at the QRS peaks, then you would see this blurred out. The artery would be completely blurred out. So there was a publication that came out. It's a little over, it's been 11 years now. And basically what they did is they took and they acquired a bunch of images, and I'll explain what a retrospective is in a minute, but basically they acquired the image across all of the percentages, across the entire heartbeat. And then they looked at and they reconstructed the images at each one of those percentages, and they showed them to the radiologists and cardiologists, and they said, tell me, I want you to look at the RCA, the right coronary artery, the left main LM, the left anterior descending with the LAD, and the circumflex of CX. Tell me, how do these arteries do they look? Tell me the sharpness. Do these coronary arteries look good? Can you make your diagnosis? And basically what they said was for low heart rates, they defined low heart rate as anything less than 70. They said that the numbers came out, excuse me. Sorry about that. If the heart rate was less than 70 beats per minute, then they liked the image quality that came out at the 65 to 70% interval. And if the patient had a higher heart rate, anything over 70, then they actually preferred a 35 to 45%, somewhere in that range. Here's an example. This patient had a heart rate over 70 beats per minute. When they reconstructed it at the 60% interval, you can see the artery doesn't look as good. The motion is blurred out. But if you imaged it at the 40%, it's a lot more crisp and it's a lot more defined. And another paper, and this was in 2008, so once again, still about 11, 12 years ago, they looked at they did the same thing. They looked at all the percentage intervals, and here I'm giving you a histogram where if the heart rate was greater than 65, slightly different than the previous publication, they said the best visualization of the coronary arteries was basically at the 50th percentile. We're somewhere in that range of 40 to 50% interval. But if it's a slower, more manageable heart rate, then almost always they were very happy with the 75 percentile. So somewhere in that 70 to 80 percentile. So obviously these two papers came out, and both of those papers had slightly different results, but they were basically grouped around this idea. High heart rates, you were actually going to be wanting to image somewhere down in the interval of 40 to 50, and low heart rates or manageable heart rates were upwards of the 70, 75 percentile. So if we're doing prospective EKG gating, we're going to just acquire the image every time at that percentage, wherever it is along the systolic to diastolic phase. And we're going to and we're going to go zero dose, and all of a sudden we're going to turn on the system, ramp it up, and collect all the data we can at that phase. Now, because life is not always perfect, realistically, instead of acquiring it exactly at that phase, that percent phase, we're going to acquire a slight padding. We're going to just actually increase it a little bit. So instead of exactly at say 45, maybe we'll do 40 to 50 or 35 to 50, something to that effect, so that we have the opportunity to collect that data. And if we reconstructed at the 35 and it's still a little too motion, 40, still a little motion, 45 is good, then okay, we got it. We got the data we needed. We did acquire just a little bit longer, but it was worth it because we were able to get the right amount of data, and we didn't know exactly when we needed to collect it. So doing this padding, though it does increase the dose of hair, it does increase the amount of data that you collect, it gives you a lot more freedom to reconstruct the data. So what are some of the limitations of prospective gating? Well, obviously, we're only collecting the data, we're taking a picture of the heart at one location on the heartbeat or the systolic to diastolic spectrum. And this kind of expects the heart rate to be consistent, obviously no arrhythmias, and we really do need slower hearts. And so if it's not well behaved, then the system is going to take a lot longer to acquire the image, because like I said, if it knows what the traditional R to R peak time is, and every so often you get an arrhythmia and it's a little lower or longer or whatever, the system is just going to keep spinning. It's not acquiring data. It's just going to sit there. The patient's going to be waiting as it collects, as it's waiting for the peak to get back to its right timing average to start acquiring the data again. And so in the total exam time can be longer with prospective EKG. Obviously, the strengths are we're not wasting radiation dose on collecting data where there would be motion, so the patient dosing is generally at the lowest in prospective imaging. What about retrospective imaging? Retrospective imaging, as I've alluded to, is basically when you turn on the scanner and you acquire the images over the entire R to R peak spectrum, or in many cases we'll do it over multiple heartbeats so that we get a good average. Now, there is a way where we can try to minimize. This is obviously the greatest amount of dose, right? So it's just turned on, it's on all the time. But one way we can collect this data, there we go. One way to collect this data and be as dose conscious as possible is we're still going to try to collect most of our data only over the diastolic phase. And depending on the heart rate, it might be more skewed towards 70% versus maybe 40%. But we're going to have it turned low for it. The system will stay on at all phases, but it will only ramp up at specific phases. And so you still have to be plugged into an EKG system, and it's still tracking that R to R peak. And it's going to still collect all this data. And irrespective if you do a full dose retrospective scan or a retrospective scan that's at some percent dose reduction, you can, because you have data at every phase, you can still go back and calculate or reconstruct the images at 10%, 20%, 30%, 40%, or any kind of mixture of that. obviously, if you're doing this retrospective scanning one, the dose, if you reconstruct an image at say 10%, if for whatever reason, the image quality is going to be a lot lower because it's just going to be much more noisy. All right. So, is there a difference if we're acquiring the data using a helical low pitch versus a sequential single spin? And in the olden days, or traditionally, if you still have 4 centimeter coverage, so 64 slice scanners, uh, when you looked at the difference between when you look at the image quality, acquiring the image both in helical versus sequential images or these axial step and shoot acquisitions, the image quality was basically the same. The doctors could still do what they needed to. The physicians had the data they needed for the diagnosis. But the dose in the olden days when you did sequential was lower because it was step and shoot. And you remember we talked about the helical overranging. And if you're going to be constantly imaging and you're having a low pitch, you're going to be overlapping the dose, the anatomy multiple times to collect all the data you need to create all of the images. And so there can be at times 40 to 60% overranging effect. The overall dose is just that much higher. You can just see sequential acquisitions 4 to 6 millisieverts versus 12 to 15 millisieverts. And this is a study. It's a little older now, so I would probably say these numbers will come down just a little bit, just by nature of having more efficient, higher, greater technology-based scanners. But when it looks, if you still have the limitation of just a 4 centimeter scanner, then doing that step and shoot is going to be by way of dose still probably one of your better options. But once again, that's just if you still have those older scanners. Many may still do. If you've moved towards at least one scanner in your hospital that is these new dual source, or as we've talked about, the single 16 centimeter, those wide beam cone angle CT scanners, then it's probably best to move most of your cardiac imaging to these newer scanners because, as we'll explain going forward, they can produce a really high quality image at a really low dose. You can still get good high quality images with the smaller field of view, the 64 slice scanners. You're just limited in how fast you can acquire the image and the radiation dose, to the limit to which you can reduce the dose. So let's talk about what the more modern day, probably the more advanced CT scanners. So in this case, we have a dual source CT scanner, originally developed for dual energy. But if I turn tube A on to 1 kV, let's say 120, and tube B to the same kV, well, now I'm still doing single energy. I'm not doing dual energy. But the CT scanner doesn't have to cover the same heart. It doesn't need to go all the way on around to 180 degrees. Because by the time tube A rotates over here to the location where tube B is now down here. So between the data we collect from tube A and tube B, we actually only have to spin half the time. So tube A only has to go 90 degrees and tube B only has to go 90 degrees. So if you are imaging at a 0.25 millisecond rotation, that's as fast as it takes to go all the way around, but you only have to go a quarter of that distance, so half for tube A and half for tube B, well, then you are actually able to image a heart that is somewhere in that 63 millisecond range. And so this is one of those beautiful benefits of having these this dual source CT scanner, is you can go fast and cover as much data at a really high heart rate. Now, once again, just remember, because the B side tube has a smaller detector, you will have a limited field of view to image the heart with, even though it's not dual energy. It's just that fact that you are still limited to 38 centimeters in the third generation dual source CT scanner, or somewhere around 29 to 30 centimeters if it's the first or second generation. Now, this is that example where if you do your image and the heart is not in the circle, in that yellow circle, you might actually have to physically move the patient to get that heart centered in there. Okay, so we obviously just discussed how we can get really fast temporal imaging with these dual source CT scanners. Now, most of these scanners, the newest one does have actually a pretty wide detector, but most of them are still narrow detectors. Therefore, all of the dual source CT scanners are still usually acquired in helical acquisition. In a traditional case, if you have this dystolic region right here that we're going to acquire all of our images in, to collect all the data in that part, you might have to pass over it 2 or 3 times as you collect multiple helical runs. So the heart is there, the body's moving, it's going to acquire, it's going to acquire, it's going to acquire. And then once you've done is you've collected all that data, and that in that phase of the dystolic, you're good. The exam is done. With the newest scanner, they have what's called the turbo. Oh, what's it called? Turbo. Oh, I can't remember it. I'm drawing a blank on it. Turbo flash. Turbo flash. Where the system, because the scanner table can move real fast, and you're using 2 tubes at the same kV, you can actually acquire all the data over that whole, let's say, 60 to 80% on your dystolic phase. You can acquire that all in just one pass because you're moving fast enough. Your detector might not be wide enough to collect all the data, but you're pushing the table through fast enough. And so if you can't collect it all in a single rotation, the only other option is to move that table faster. And this system is really good at that. The only issue, though, is if you throw in arrhythmia, then the system might pass the patient through, but it might not actually acquire the data and has to stop, back up, and start over again. But that's a minor limitation, I think. So when they looked at this in 2015, once these new dual source scanners came out, once again, image quality was always the same, but the radiation dose was much lower, being able to acquire these really high pitch acquisitions compared to the step and shoot axial imaging for the 4 centimeter coverage. So we already said 4 centimeter coverage, axial step and shoot was better on the older scanners than the helical. Now we're saying that high pitch is even better than that. So as you can kind of see, as we're moving forward, 2008, 2009, doses were higher. Now 2015, the doses are coming much lower. I think you're going to see that progression as we keep stepping through. As we get farther and farther along in time, the technology is helping us get the doses much, much lower in the cardiac imaging. So once again, the goal here is to get the whole heart. So we're talking about a 15 centimeter heart. So the 64 slice scanner, it at best is 4 centimeters. So, just pictorially here, we're only able to ever image a certain part of the heart and, of course, the artery at any one rotation. So therefore, we obviously have to use helical pitch to collect that and collect it as we increment and step down through the body. Now, if you have that wide angle 16 centimeter 320 slice CT scanner, for the most part, you can get pretty much all the heart in a single rotation. Therefore, it's a one rotation. You've collected all the data at that heartbeat, at that percentage of the phase, and you've got it, and you can move on. This does require it's probably the fastest way you can acquire the data, and so it does require less patient motion. It produces an image with less patient motion. It can require less contrast because once you've injected the dose, the IV bolus, the IV dose, once it gets to the heart at that right timing, you acquire the image, and in a snap of your finger, you're done. And so the exams can be really quick. And the biggest caveat to this, and probably the disadvantage of this, is because you're done in a single rotation, 0.25, 0.275 seconds, and you're done. You got to make sure your contrast bolus timing is right on. If you miss it, you might actually acquire it before, or you might, well, probably not after, but if you acquire it before, then obviously the image is going to look very diluted. So not all of these, depending on how fast that scanner can go or how fast your heart rate is, and the dystolic phase might be truncated slightly. If that's the case, then you might still need to acquire the multiple spins to add up all the data at that particular dystolic phase. And so if you look at the Canon GE scanner, those are the two wide cone angle scanners on the market. They can spin as fast as 0.275 milliseconds currently. And the GE scanner has said that at some point in the near future, it will be able to go 200 milliseconds or 0.2 seconds. That's pretty darn fast. But let's take the numbers as they are now at 275. If you, once again, you really only need about 1/2 plus fan angle. So in this case, you can image at 137 milliseconds. That's reasonable. That's respectable. If you do 2 spins, so you have to image over 2 heartbeats, now 275 single rotation twice at that specific dystolic phase, you're down at 69 milliseconds. So these wide angle and the high turbo flash, the high pitch dual source CT scanners can basically image the heart at the exact same, with the exact same speed. One just has to do it twice. The other one just has to go real fast. So when you look at the way we reconstruct these images, iterative reconstruction, which helps to reduce the amount of noise in the image, iterative image quality wise, there was no difference. Dose, if you reduce the amount of MA you use and then use the iterative reconstruction to clean up that noise, so iterative reconstruction compared to filter back projection, you can still get you can get pretty substantial dose reduction using those new reconstruction algorithms. And I would argue iterative reconstruction is pretty standard now. So it's not that paper, which came out a few years ago, is probably a little out of date. But even more so now, when we compare iterative reconstruction with deep learning, this is just one of our patients. He's got a univentricular or a Fontan patient. So we got one ventricle. And so that's why the actual IV contrast is rather diluted in this image. But the image quality itself is fairly noise-free. Here's another patient with a standard cardiac anatomy. Once again, iterative reconstruction. This is a larger patient, so you get a little bit more noise throughout the soft tissue, noise overlaying in the heart. And in this case, with the deep learning, that noise is basically gone. Now, the other nice thing, and this is specific to the two vendors that we have, which is GE and Canon. If you look at the sharpness of the image, they not only try to clean up the noise, but they're also trying to enhance the structure, and they're trying to make the spatial resolution much more finer. So I would argue the bone structure is a little tighter, a little more edgy. And so that would be the same for the arteries and whatnots. If I actually had a close-up image of the heart, you'd probably be able to see the coronary arteries, and the edges would be a little bit more enhanced, a little more distinct. So so those are just the images. Now let's look at what are the doses that we're typically dealing with now, comparing prospective EKG, which tends to be the lower dose approach. So if you're doing a single spin, 320 slice scanners, you're somewhere in the 0.6 to 1.7 millisievert range. So that's pretty respectable. It's not that much more than a normal body acquisition. High pitch dual source CT scanners, they're somewhere in the 0.5 to 4 millisieverts. Now, obviously there's a range because that's just, you're looking at multiple institutions, multiple hospitals and how they do it. The fact that it can be as low as 0.4 demonstrates that the system itself, technologically, when optimized right, is a very robust low dose acquisition technique. And then when you look at the conventional scanners, your quote unquote 64 slice scanners that are limited in their approach, even when you use iterative reconstruction to help clean up the noise, so therefore you can reduce the MA, these systems are always going to be they're older technology, so they're going to be higher radiation dose. So about 1.5 to 3.5 millisieverts. So the values of the radiation dose, what you will see in Thailand, are going to vary from site to site, institution to institution, and more specifically, technology to technology. So looking at the data that Dr. Panayiotou developed, of course, they have some coronary CTA exams, and they looked at prospective versus retrospective. And looking at these values, you can see national diagnostic reference levels are set for the prospective, roughly just shy of 19. milligray, and for the coronary CTAs in retrospective, a little over 60, compared to your fellow compadres in Japan and Korea, and they only have just one value for the two. The US over here in the West really don't have any values. In the US, we have values that are set slightly differently. They set what are called dose notification thresholds, in which case these are not necessarily diagnostic reference levels. These are values that a lot of, for example, the ACR and a few other institutions, or I should say societies, what they basically said is if you ever have a retrospective study that exceeds 150 milligray, then that's probably too high and you should do a root cause analysis to review what went wrong. And for prospective, it's roughly 50. So these are just values where you would set on your dose monitoring software to just determine if it's too high or too low. The acquisition, not too low, but the acquisition of that particular patient, how it compares. So it's not a diagnostic reference level, but it's an internal hospital value. And you can just see how they are much higher than the diagnostic reference levels that Thailand has. So kudos to Thailand. These values are great. These are probably respectively low. And so you can use these to just look at the overall values you have at your hospital and determine, if it's above this value, either of these values, then the question is the image quality necessary for the clinical task, or can we reduce the radiation dose but still maintain the same clinical outcome? So what are the overall, so kind of summarize it. Let's put some of this, these are all a bunch of pieces. Let's start putting some of this together. So what we're going to do is steps to optimize cardiac CT. We want to minimize the scan range. We want to do our best to image a heart that has a reasonable rate of beats per minute. If you can't do it because your scanner isn't quite fast enough, we've talked about the newer scanners, the dual source or the single spin with the wide beam width. Those systems, you do kind of need to use, your patient population probably uses a lot more beta blockers. The best way to get the best dose optimization possible is using the EKG to current modulation. And we talked about using the lowest kV possible, as long as the system has can produce the right MA to keep your noise down. And the lower kV gives you obviously dose reduction, but it also gives you a good contrast enhancement, a little bit more of a pop to the image. And then depending on how you image, what's the clinical task? If it's something such as inherently high contrast imaging, such as calcium scoring, then really you can enhance your dose reduction even more by reducing your MA manually, because you just don't need a lot to do calcium scoring. Now, depending on the type of scanning that you do, there may be reasons why you would do a retrospective study. Maybe the heart is just so fast and you just don't feel comfortable doing prospective EKG, or you do want to see the heart as it is at all phases of its heartbeat. But for those of you that are doing, for the most part, prospective EKG triggering, if you use sequential scanning for the older systems, the 64 slice scanners, that's going to be a lower dose than the really low pitch helical. And then if you can do it with the wider beam width ones, well, that's great too, because it's usually one or maybe two spins and you got all the data you want. You can, of course, use the newest model scanners with the turbo flash, where you go really fast through the scanner and you're using the same kV on both X-ray tubes. So I probably should have added that also there too. So high pitch imaging. If not high pitch, then you're probably still doing axial or sequential imaging for the heart. Then use iterative reconstruction to further reduce your MA. And that's just with all of the scanning. I almost assume that's standard. I probably should just take that off, because if you're not doing iterative reconstruction, either your CT scanner doesn't allow that because you just have an older scanner and you're stuck doing filter back rejection, or you just haven't turned that on. That said, I will be the first to admit when you use iterative reconstruction, it does fundamentally change the type of image, the texture, of course, and it can soften the edges in the image. I showed you this last week. So there may even be some doctors out there that just can't look at an iterative reconstructed image in the heart and feel that that's appropriate, because it didn't either soften the image a little too much or whatnot. So these are probably the kind of the higher level steps to optimizing the image. And it really does come down to, kind of, as I would say, even higher level. It really just depends on the technology that you have. But that said, even the older scanners, 5, 10, 15 years, well, not 15, but 5, 10 years old, you can still acquire a really good cardiac image. Your dose will probably just be a little higher. All right, that's all I have for you.
Thank you so much, Sam, for the comprehensive reviews for the cardiac CTA. And อาจารย์ปานคะ
ค่ะ
Do you have it?
ของประเทศไทยที่ดูแล้วมันต่ำเนี่ยเพราะว่าโรงพยาบาลที่มีจำนวนเคสพอจะเก็บมาให้20รายเนี่ยค่อนข้างน้อยนะคะแล้วก็อันที่เป็น prospective เนี่ยแล้วมันต่ำมากเพราะว่ามีโรงที่เก็บมาให้เท่าที่จำได้นะคะมี5แห่งเพราะฉะนั้นมันก็อาจจะไม่มันเป็นได้แค่ local DRL แล้วก็เครื่องมือเป็น high end หมดเลยคิดว่าน่าจะมีสัก2ที่มี turbo flash เพราะฉะนั้นมันก็เลยค่อนข้างเอฟเฟกต์ค่อนข้างเยอะเวลาที่จะไปใช้จริงๆคงไม่ใช่เป็น national DRL ประมาณนั้นค่ะคืออย่าเอาไปใช้ว่าต้องไม่เกินเท่านั้นเท่านี้แต่ถ้าดูอันที่เป็น retrospective และเทียบกับของญี่ปุ่นจะเห็นว่าตัวเลขมันจะเท่ากันนะคะอันนั้นก็คงใช้ได้แต่ prospective เนี่ยคงเป็นได้เฉพาะบางที่แล้วก็ถ้าใครจะเริ่ม prospective อย่าไป fix กับตัวเลขที่เห็นว่ามัน 18.7 หรืออะไรแบบนั้นเพราะว่าการที่ทำ prospective หลายคนอาจารย์หลายคนคือเขาเฝ้าเองเขาเข้าไปอยู่ตรงนั้นด้วยหรือไปอยู่หน้างานด้วยนะคะพอ prospective dose ก็เลยจะลงมาต่ำได้เยอะส่วนใหญ่แล้วจะ comfortable อยู่ที่ retrospective แต่ก็อยากให้เชียร์ว่าที่ไหนพอทำ prospective ได้ก็ค่อยๆขยับเข้ามาอย่ายึดตัวเลขนี้เป็นหลักให้รู้แค่ว่ามันน่าจะลดได้เราลดได้เท่าไหร่ก็ดีกว่าไม่ลดเลยนะคะจะลดลงมาแล้วเป็นแค่สัก30ก็ยังดีอย่างเงี้ยอยากให้ใช้มันแบบนั้นมากกว่าเพราะมันอย่างที่แซมก็จะพูดบ่อยๆมันไม่ใช่ right or wrong มันไม่ใช่ได้ตกมันไม่ใช่อะไรล่ะคะคือดีหรือไม่ดีอะไรอย่างเงี้ยมากกว่า
You are so good. You know what are we talking about because you show the slides that we have the data.
I think I'm learning Thai, but I probably just heard DRL.
So that's good. So Dr. Parithai just mentioned that the number probably we have like a very small small sample size. So which means it's probably not like the real national DRL, but it's maybe local DRL, but it's a good step to start. At least we have some data collections, and she talked about some limitation that for the prospective getting study, the number is low. Maybe because we have like a high-end technology, and also the radiologists monitor the patients by themselves, almost every patient, and this is in the academic hospital. So which means we are very careful on image quality and radiation dose. So, but at least it's like a first step for us to watch and to learn the process. Mm-hmm. So we still need more data.
Yeah, that's true.
I think that when starting prospective, do not I have to come to about 20 or 18. Because from 60, if you can go down like a 30, that is great enough.
Yeah.
So don't use this as the target.
Yeah, and that's very true, because ultimately, wherever you are, high or low, you need to look at your image quality, as was just said, and then you obviously need to ask the question: am I getting the right diagnostic information? And so at times there is a reason to go a little high. Some of these patients, if they have a high heart rate, you may need to open up the padding. So even though you're doing prospective, you're actually acquiring more of the systolic phase, so that you can then look at maybe 3 or 4 percentage, 3 or 4 values on that percentage. And so yes, there is a reason why the dose can be high. But even though, yes, this might be a small percentage from a few academic centers more locally, I still think it's really impressive, because most places, in the European and Australian around the world, most places haven't quite figured this out either. So CTAs are not you don't do as many cardiac CTAs as you do abdomen pelvis. So you'll never have a lot of data, but collecting what you have, and that's a great starting point. So I think that's just kudos to you guys for collecting this data.
And I think one thing is the key is like a patient preparations to get the right heart rate, to get a good image quality. So that's why nurse can get involved and help us to prepare the patients. Mm-hmm.
Yeah. Yep. Yeah. In pediatrics, obviously, there's a lot of just trying to keep the patient calm. The pediatric patient will usually always meet with their referring physician first, and they will talk to them, and they assess how likely, they obviously can do them EKG and they can measure the heart rate, but then they can also measure, the likelihood of that patient being nervous, which would increase the heart rate, or if they can work with the patient to keep the patient's heart rate naturally lower or closer to baseline, then it helps us limit how many beta blockers we need to actually use in our patient population. So yeah, it's a big team effort. It's not always, but some centers, especially in adult hospitals, where it's just, you don't have time to mess with that, then you just prescribe the beta blocker for every patient and every patient gets a beta blocker, and then irrespective of the technology, you should be able to image the heart at the right systolic phase.
So thank you so much. I think we don't have any more questions this time.
Yeah, cardiac CTAs, a lot of them have been very well developed. And so most scanners, when you buy the scanner, it has some good CTA packages on it. Mm-hmm. But for whatever reason, if you don't, like I said, lowering your KV, using EKG tube current modulation, those are great ways to get the doses lower. And then obviously, as Dr. Panyatai mentioned, having doctors there observing, that's pretty common. Radiologists working closely with cardiologists actually at the scanner. And those are really great ways to keep your doses down too. And then using the best technology you have at the time. So obviously using iterative reconstruction, if you have deep learning, that's another great way to reduce your doses. And then getting the faster scanners. It's just the faster you go, the better the image quality. It just always will be. And so less repeats.
Sure. So thank you so much, Sam, for give us an excellent lectures as always. And I will give you 2 weeks spring break and we will come back. I give you 2 weeks spring break. So, and we will come back again for the next modality that we are going to talk about, interventional radiology and also fluoroscopy. And after that, we're going to talk about the DR and CR and also mammogram. So it's going to be how many weeks? 7 weeks, I think. Yeah, 7 more weeks to go to finish the whole course. Mm-hmm.
All right. Well, happy holidays to everyone in Thailand. I will take this opportunity to throw water on all my friends here in the US.
So because you're gonna have 2 weeks break. 1 week is for like a family visit, and second week is water festival. Mm-hmm. Yeah.
Yep, I love it.
โอเค yeah so ก็สำหรับทุกท่านนะคะเหมือนเดิมนะคะทำประเมินนะคะแล้วก็ส่งใบประเมินภายในวันพฤหัสตอนเที่ยงคืนเพื่อที่วันศุกร์จะได้รับไอ้ CME certificate นะคะแล้วก็เราจะหยุด2 อาทิตย์ นะคะให้ไปเชงเม้งไปพบปะญาติกลับบ้านนะคะไปเล่นน้ำสงกรานต์นะคะแล้วเราจะกลับมากันอีกทีหนึ่งวันที่18เมษายนนะคะในเรื่องของ fluoroscopy แล้วก็ในเรื่องของinterventional IR นะคะยังไงเดี๋ยวก็กลับมาเจอกันอีกทีนึงแล้วก็ระหว่างนี้นะคะหยุด2อาทิตย์นะคะสามารถมาดูย้อนหลังได้นะคะมาเช็คที่แบบตอนฟังอาจจะฟังไม่ทันเก็บข้อมูลได้ไม่หมดมาฟังซ้ำอีกทีนึงได้นะคะทาง YouTube Channel Imaging Academic Outreach Center นะคะหรือว่าทาง Facebook Live ซึ่งสามารถมาดูย้อนหลังได้นะคะแล้วก็ขาดไม่ได้เลยก็ต้องขอบคุณสปอนเซอร์นะคะก็คือมิชชั่นนี้เราก็มีสปอนเซอร์มาซัพพอร์ตนะคะขอบคุณบริษัท Bayer นะคะ Philips แล้วก็ GE นะคะที่ช่วยมาสนับสนุนในเรื่องของการศึกษาของเรานะคะของทั้งรังสีแพทย์รังสีเทคนิคแล้วก็นักฟิสิกส์ของประเทศไทยนะคะที่มาช่วยร่วมในโครงการนี้ก็ขอบคุณทุกท่านมากๆค่ะขอบคุณค่ะอาจารย์ปาน Thank you so much Sam see you next 2 week bye bye